Well, good afternoon and welcome, everyone. My name is Bree Science, and I am the Congressional Hispanic Leadership Institute's Programs and Administrative Assistant Manager. Before we begin today's discussion, I have a few items to discuss. First, we ask that you help us share the speakers' points of view as well as your own. So please be sure to follow us on Instagram and X at the CHLI. After each panel discussion, there will be a time for questions and answers. The discussion, including the questions and answers, will be live streamed through Zoom and will be uploaded to our CHLI YouTube channel. Now to kick off the program, I will pass it on to CHLI's Director of Programs and Internships, Nicole Marin.
Thank you, Bree, and good afternoon, everyone. Muy buenas tardes. Welcome to CHLI's Congressional Public Policy Briefing on Health. The Congressional Hispanic Leadership Institute, or CHLI as we like to call it, is the premier organization founded by members of Congress to advance the Hispanic community's economic progress with a focus on social responsibility and global competitiveness. Founded in 2003, CHLI is a 501c3 nonprofit and the only bicameral, bipartisan, Hispanic-led and Hispanic-serving nonprofit based in Washington, D.C. CHLI is dedicated to fostering a broad awareness of the diversity of thought, heritage, and interests and views of Americans of Hispanic and Portuguese heritage. Our year-long public policy briefing series sponsors are Amazon, Capital One, Charter Communications, Chevron, Citi, Coca-Cola, Dell Technologies, Dominion Energy, Edison Electric Institute, Gates Foundation, Green Hills Software, Opportune, Pacific Gas and Electric Company, Pfizer, ServiceNow, and 2042 Media. Thank you for your support. I also want to thank the CHLI team here today as well for their work in putting together this program. They are Bree, Angela, Sophia, Andres, Stephen, Bruce, Talise, Tia, and Maite. The CHLI Congressional Public Policy Briefing Hill series provides a platform for an in-depth dialogue on current public policy issues that affect U.S. Hispanic and Portuguese communities. However, CHLI does not attempt to influence legislation. The purpose of our briefing is to educate and inform members of Congress, their staff, and the Hispanic communities across the country. Today, we will be discussing healthcare and why screenings, treatments, and accessibility is pivotal to improving the healthcare experiences of all Americans. There are many times that we don't pay attention to certain details in legislation because it may not impact us directly. This is a chance to dive into legislation and learn from different perspectives. Our guest speakers will provide that insight today. Please take the time to listen to all the different perspectives shared. Before starting the program, I would like to take a couple of minutes to promote one of our partners, Catch Skills. Catch Skills is about making learning count, no matter where or how it happens. We all pick up skills in different ways, on the job, through training, in school, or even from everyday experiences. The problem is, a lot of that learning isn't officially recognized. Catch Skills is here to change that. It's a platform that helps people track and showcase their skills, formal or informal, so they have a complete picture of their skill sets. For organizations, it means being able to measure the impact and outcomes of their work and connects people to the right opportunities. Catch turns everyday learning into skills that drive growth. Throughout today's program, a CHLI team member will be logged on and pinned along with the rest of our panelists so you can scan the QR code on the screen at any time and log your first learning experience. At the end of the program, a member of our team will also share a suggested prompt that you can use to submit your very first learning log, so stay tuned. In the meantime, feel free to once again scan the QR code on the screen. It will take you directly to catchskills.com where you can sign up and start tracking your skills today. Now, I would like to introduce CHLI's chairwoman, the Honorable Ileana Ros-Lehtinen. Chairwoman Ileana Ros-Lehtinen was the first Latina elected to the U.S. Congress, where she proudly served from 1989 to 2019, including as chair of the House of Foreign Affairs Committees. Born in Havana, Cuba, she built a legacy of leadership in foreign policy, Hispanic representation, and supporting women in politics. She now serves as the Senior Policy Director at Aiken and continues to champion Hispanic and Latino leadership as Chairwoman of the Congressional Hispanic Leadership Institute. Chairwoman, welcome.
Thank you so much, Nicole. What a sweet introduction. Good afternoon, everyone. Muy buenas tardes. I am Ileana Ross Layton, Chile's chairwoman, and I'm so honored to welcome all of you to Chile's Congressional Public Policy Briefing on Health. Today's discussion is about finding real, workable solutions to strengthen our healthcare system. Healthcare is one of the most important issues facing our nation. It impacts every individual and every family. And while the challenges are complex, there are clear, practical steps that can make a real difference. We know that early screenings and timely care can dramatically improve health outcomes and reduce long term costs. We also know that continued innovation leads to better treatments and longer, healthier lives. Doesn't that sound good? And that's why today's focus on screenings, on treatments, and access is so important. When these three pieces work together, we improve lives and strengthen the health of our entire nation. But we must also recognize that barriers remain, whether they are logistical, regulatory, or systemic. And that's where public policy plays a critical role. At Chile, we are committed to ensuring that all voices have a seat at the table. There is common ground when it comes to making healthcare more accessible, more efficient, and more effective for all of us. And that's what today is all about, coming together to explore practical bipartisan solutions that deliver better healthcare for all of us. I want to thank our speakers and our guests for sharing their insights today and moving these important conversations forward. I look forward to a thoughtful dialogue with each of you, and I know that we will have many great questions from our audience that truly reflects the value of collaboration in our healthcare system. Muchísimas gracias, muy agradecida. Thank you to all, Marianne and Nicole. Great forum that you've put together for us. I'll turn it over to you.
Thank you, Chairwoman. And before we start, I would like to take a pause so that we can take a quick screenshot that will serve as our picture. So those on the team, if you can help us here. All right, I will make a countdown and you can take the screenshot, okay? 3, 2, 1. All right.
What a great idea. Thank you.
Thank you. And thank you for posing for that photo. Now, I would like to introduce the moderator for today's discussion, Chile's President and CEO, Marianne Gomez-Horta. Marianne Gomez-Horta is the President and CEO of the Congressional Hispanic Leadership Institute. Her previous experience includes serving as a corporate marketing executive with Coors Brewing Company and McDonald's, working as a national alliance consultant with pharma, and leading Hispanic business development for public relations firms. Marianne serves on the boards of the Hispanic Association on Corporate Responsibility and the American Latino Veterans Association. She is a national advisor to the Women of Hispanas Organized for Political Equality's Binational Leadership Program. Most recently, Marianne also completed the Presidential Leadership Scholars Program, Class of 2025. Congratulations, Marianne, and welcome.
Thank you, Nicole. Thank you again, Chairwoman Ileana. Thank you. Appreciate that very much. So thank you again, everyone, for being here. I'm going to start off with introducing the panelists. So the conversation overall today, in addition to what our chairwoman explained, is also going to be taking a look at, as you can see from the introductions that I will make, initiatives that are here in the United States and also abroad. A lot of times we think about maybe just some of the domestic issues, but this is also an opportunity to really look at some global and international issues that are in the health arena. This panel will explore practical, different solutions, again, bipartisan solutions that advance healthcare. And so with that, I'm going to go ahead and jump in. And the first person I'm going to introduce is Mr. Chris Palombo. He's the president and CEO of MAP International. Christopher is energized to lead strategic growth, build robust partnerships, and drive large-scale global initiatives. He is dedicated to expanding access to healthcare for underserved populations, and with deep commitment to mission-driven organizations, he has consistently championed initiatives that improve access to life-saving medicines globally. His career includes a distinguished tenure as CEO of Dispensary of Hope, where he helped establish the organization as a leading force in charitable pharmaceutical distribution in the U.S. Leadership establishing the U.S. charity pharmacy industry. He's also been a key player in advancing the global medical supply surplus industry and his leadership in the Medical Care Access Coalition. He's also been involved as a healthcare social enterprise and featured by the Bureau of Primary Healthcare as an example of a large-scale healthcare transformation. Thank you again, Chris, for joining us. Next, I'm going to introduce Jonathan Hallion, is the head of U.S. Federal Affairs at Hallion. He represents the company before Congress, the White House, and federal agencies focusing on consumer healthcare and innovation. Jonathan works with brands like Advil, Sensodyne, Flonase, Tums, and Centrum, just a few over-the-counter medications that I think some of us are familiar with. He also collaborates with trade associations in Washington to promote innovation, availability, and affordability in over-the-counter or OTCs public policy. Thank you again, Jonathan, for joining us. Next, I'd like to introduce you all to Jeanette Contreras. She's a prominent patient and healthcare advocate with over 20 years of experience dedicated to improving health outcomes for underserved communities. Before establishing the Organization for Latino Health Advocacy, Jeanette founded the Latina Health Collab, a consulting firm aimed at engaging diverse stakeholders in public health advocacy. Jeanette has held leadership roles in several national nonprofits and has over a decade of public service in the U.S. Department's Health of Human Services. Thanks again, Jeanette, for joining us today. Next is Joel Barthélemy. Joel is a U.S. Marine Corps veteran, so thank you first for your service, dear. Is the visionary founder, chairman, and CEO of Global Med, where his mission is to eliminate disparities in healthcare access through cutting-edge technology. With more than 30 years in technology and healthcare innovation, he has guided Global Med to deliver over 6 million virtual consultations in over 60 countries, empowering some of the world's largest virtual care programs, including those for the U.S. Department of Veteran Affairs and the Department of Defense, Bureau of Prisons, and numerous other government agencies and entities worldwide. Joel serves as a fellow of the American Telemedicine Association and serves on numerous advisory boards, including the Arizona State University Health Futures Council and the Salvation Army Board of Directors. He is dedicated to advancing equitable healthcare access through innovation and service. A Marine Corps Reserve veteran, Joel's leadership philosophy is deeply rooted in the values of service, integrity, and mission-first commitment. Thank you for joining us, Joel.
Thank you.
Next is Dr. Arif Kamal. Dr. Kamal serves as the first ever Chief Patient Officer at the American Cancer Society, where he leads the organization's efforts to improve cancer outcomes through patient-centered programs and services across the communities worldwide. As a practicing oncologist and palliative care specialist, he brings clinical and academic experience in quality cancer care, patient navigation, and essential services that ensure patients, caregivers, and families are supported throughout their entire cancer journey. His work reflects a career-long commitment to values-based, compassionate care and advancing innovative, evidence-based solutions to reduce the burden of cancer. So with that, thank you again, Dr. Kamal. Thank you for everybody for joining us. Just for the audience as well, as a reminder, we will have this conversation. As you think of questions, please put them into the Q&A portion of the Zoom webinar, not in the chat. But if you have some other suggestions, some links for people to learn a little bit more about any of these initiatives, or maybe something you're working on that you would like everyone to learn about, please put that in the chat. So we look forward to your questions towards the end. I'm also going to start with a round of questions, first to each panelist. Very specific question for them, to each person kind of give a little bit of information and texture to what they're doing, how we can get involved. and then we'll wrap up with some questions for all of them. Again, like always, one question is assigned to one person, but if you have something to add to it or you have additional information for the panelists and the audience, please jump in. We want this to be a dialogue. So first I want to ask a question to Chris. If you can please share with the group a little bit more about MAP International, what the organization does, and maybe what you're working on right now, what may be some of your priorities.
Yes, thank you so much. Would love to do so, and I'm just honored to join CHLI today and these incredible panelists. Cannot wait to hear from them. But yeah, MAP International, first off, let's talk about the need globally in the United States. The United States enjoys an incredible healthcare system. It has its weaknesses for sure, but it has its strengths. And then if you think about developing nations, there is a real range of capability there, and even issues such as basic primary care, let alone more robust elements like acute care hospitals, and then medication access, then refrigerated medication access, then oncology. As we get into that sophistication, some countries get knocked out because their healthcare systems are so limited. So MAP International focuses on those countries. We also focus on the US need. In the United States, we have about 27 million uninsured. That distinction used to mean more, but today there's a lot of underinsured as well, and that's something north of 40 million people. So these are incredible needs. At the same time that we have such significant need globally, about 2 billion people globally lack access to medicine. I said 27 million uninsured in the US are included in there. We also have this other wild experience where in the United States and in Europe and in Australia and other locations, there is enormous access to medications, supplies, consumables. And that area of work for the United States is 15% of our GDP. So all of that volume, out of all of that volume, there is often surplus. And that surplus often will end in garbage dumps. It'll be incinerated. It'll remain unused. And we thought this was a terrible situation at MAP. So we began our work many years ago to align the two. And that's called stewardship, right? Linking surplus with need. And that's what we do globally. I'll say a couple more comments for your listeners. You know, if you're not a pharmacist, I'm not a pharmacist, but there's about 700 items that are important for human health, right? Those items, you know, what we'd call primary care, those items, broadly speaking, fall into about 5 chronic illness categories: depression, anxiety, adult respiratory, diabetes, hypertension, hyperlipidemia. And then, you know, antibiotics, antiparasitics, antifungals are also important. That's about 700 things. And they're very important. And the same need in Iowa is the same need in Sierra Leone. So when you think about that, when you think about hospital supplies, surgical supplies, all of that volume needs to often go where it is necessary. So MAP International, think of us as a massive distribution center in Brunswick, Georgia. And then we have 3 consulting shops. One works with manufacturers around their generosity. One works with partners and governments around receiving that product. And then we're a charity. So we raise a lot of money to make that medicine flow through. And for those of you who are interested, we cost about a little less than 15 million a year. And let's see, we're 10 months into the fiscal year and we just shipped $1 billion a few weeks ago.
Wow. Wow. So just really quickly, Chris, in case there's some people joining us, again, we wanted to make this a very broad educational opportunity. Can you just very quickly share with the audience, what does uninsured mean versus underinsured?
Yes, thank you so much. So in the United States, where our health system has huge gaps, one is folks who do not qualify for private health insurance coverage, a payer coverage for their care, or public, Medicare, Medicaid, government funded. And that group is the 27 million who are left as self-pay. They have to cover their own. And who are those people? Probably the person who would cut your hair, probably the person in the United States who'd cooked your meal or served you at a restaurant. If you stayed at a hotel, the person who made your bed. These are working class folks who just have no coverage. It just is not included in their employment.
Okay, perfect. Thank you. Next to Jonathan. So give us a little bit of perspective of what you're doing at Halion and how your role, you know, how the Halion's role plays in healthcare, and what are some of the recent projects or initiatives that you are all focusing on regarding healthcare access? Because I know we've talked about it before, and you've shared that with us, and even our interns as well. So if you can share a little bit about what Halion is doing and your efforts as well.
Sure, no, I think that's a great transition. And if you hear Chris's, sort of themes, right? There is an issue here when it comes to access, whether that's you being able to find a pharmacist within your zip code, or even finding a reliable primary care physician, right? There are a variety of gaps that exist in the U.S. healthcare system. I think sometimes in the agriculture space, we talk a little bit about food deserts, but there are also health deserts too. And so I think when you think about where where we need to show up, right? Where do we address some of these gaps and shortcomings in the US healthcare system? Over the counter usually tends to be the first, line of defense, right? You think
Right.
about the mornings when you wake up with a headache or when you have a sore throat. Most people, go to the pharmacy and go straight to the over the counter portfolio. And so we are that first in line of defense for many families across the board, regardless of socioeconomic status or income. I think one of the challenges that we have in the US is that there are so many products that you can find over the counter, whether that's Canada, whether that's the UK, and you just don't have that here, right? So we've talked a little bit about innovation earlier. And so, people are starting to, take a look, right? You think about the sunscreen issue, right? And sunscreens, I think a lot of folks have said, well, why is it that we can't find this like in the US? And it turns out it's because, we're still behind, right? We still,
Yeah.
haven't, caught up with some of our counterparts in Europe and elsewhere. And so I think for us, if you ask us what we've been up to, what we've been, sort of looking into, certainly, as I'm sure many of you are aware, the over the counter monograph user fee agreement with FDA is up for reauthorization
Mm.
by September of this year. So we've got to reauthorize that. And the goal there is to bring innovative treatments over the counter. And I think one thing that you can say definitely is that over the counter policy isn't a Republican or a Democratic issue. Everybody wants to feel better. We should have more health in more hands. And over the counter is one way to do that. I think, and you mentioned a little bit about some of the conversations we've had before, right? And you look at some of these systemic gaps. And I always love talking about toothpaste for that one reason. If you look back at the regulatory framework that exists, we in many ways still consider toothpaste to be a toiletry, which goes back to 1957. So you've had a huge
Mm.
innovation in the space on how to help address, gum recession or even tooth sensitivity. And yet our regulatory frameworks are still behind on those issues.
Right.
And so I think when we talk about, delivering everyday health for humanity at Halion, it's not just a nice phrase. It's something that we look at from a public policy perspective to try and look and see where those gaps exist, because we know that those gaps impact working class families. We don't, we see them, right? We meet customers where they're at. We meet patients where they're at. And so we see those gaps manifest in real time. So for us, it's really trying to bring some of those innovative treatments that exist in Europe, that exist in Canada, and bring them here to the US. And again,
Yeah.
I think you've put a great panel together with different perspectives. And I'm excited to hear what the other folks in the call will share with you today.
All right. No, thank you, Jonathan. I just wanted to add, it's really interesting because many of us of Latino origin, I have family in Mexico, right? And so I have an aunt who has a home in Chicago and still has a little home in the hometown where they grew up in Mexico. And she comes back with medications that she was able to get, over the counter in a farmacia, in a clínica from some doctor in Mexico that she can't get in Chicago. And so we're always in this tough love with the family because it's like, but does your doctor here know that you picked that up over there? Like, and then my pharma days kicks in and is like, is that the real formula? So you start kind of getting a little worried. So I think, and that's one of the things too that comes up on both sides in terms of the regulatory part of it and the advocacy side, I think too, is like we want to be able to have that, but we also want to feel comfortable that our doctors here, our systems here have been doing their, check and balance to make sure that we're getting the best as well, and that we don't feel like, we're bringing in, some crema from Mexico that, we can't get that cream here type of thing. So I know I'm not speaking to just my family. So but
Finding that sweet
those are things
spot.
that
You're
come
right.
up, you know, those are things that come up. Next, Jeanette, so I understand that you just became a new board member too of Directors at Healthy Women, so congratulations. Keeping busy there, lady. So according to the census, the median age of Latinos in the US today is about 30 years old. We're the intersect of the younger millennials and the older Gen Z, kind of the prime of our lives, but as a block in terms of the census, we're still a little bit younger than the rest of our US population, brothers and sisters. So tell us a little bit about in the space that you work in from Latina Health. What are some of the issues that you're working on or the advocacy part of it that you're working with women in particular in our communities?
Yes, thank you so much for the opportunity to join today's panel. I just want to start off by saying that at the Organization for Latino Health Advocacy, we're being very intentional about addressing the health issues that stand to impact our largest demographic, which are these young women. And so we really are keeping these young women top of mind in our advocacy. I think it's really powerful that I raise awareness about how autoimmune diseases disproportionately affect women and Latinas in particular. We experience higher rates of some autoimmune diseases such as lupus, rheumatoid arthritis, and type 1 diabetes. Selena Gomez is a high profile example of someone living with lupus, right?
Yep.
Which falls in line with the studies that show Latinas have a higher incidence of lupus compared to other groups. So managing an autoimmune disease, it's a challenge, chronic disease to manage, right? There are many doctor visits, therapies to manage. Patients often have to navigate complicated health insurance approval processes to access the medications they need. One process is called step therapy. It's when an insurance company requires patients to try certain medications before insurance covers the medication that their doctor believes is more appropriate. And so I wanted to also raise awareness of the bipartisan bill that was just introduced, a bipartisan bill that was introduced in the last Congress by Senator Lisa Murkowski and Representative Brad Wenstrup in the House. It's called the Safe Step Act. We'd, of course, like to see this bill reintroduced in Congress. The legislation would simply create a reasonable exception process to ensure that there's no delay in access that could harm patients. So instead of having to go through all of these approval processes to get the medication, what I characterize as your insurance dictates your access to care instead of your doctor, this legislation helps to ensure that patients and doctors lead the treatment plan without having to go through these cumbersome prescription drug policies that delay access to care.
Okay, and then you mentioned there's like a step therapy type of thing. On an average, how many steps is that to this step therapy?
Right. Well, so some step therapy. So depending on an example, so my son needs his ADHD medication. It's hard to diagnose a 9-year-old, right? This is a few years ago when he was really young. And the doctor says, oh, he'd really do well. I say, a lot of my patients do well on this medication. Let's see what type of insurance you have. And I said, well, why does that matter? And he says, oh, because you have to try this one first before you can get that one. You have to fail on this before I can give you the one that you need. And so this is where I say that the insurance companies are dictating care. And when you're managing living with lupus or an autoimmune disease, where you're trying to find something that works for you that might not work for somebody else,
Right.
Knowing your doctor knows best. Your doctor knows well with your condition and your, unique person as a person with unique, predispositions. This is the one that I recommend for you. The insurance formularies, the prescription drug policies are so that they really do want to say, okay, well, let's try these cheaper ones before you get to the brand name or before you get to the one that your doctor wants.
So this legislation helps with that and trying to cut that down?
It does, yeah. In some cases, it'll say that the insurance company needs to provide an approval within 24 to 72 hours so that you don't wait. You can file an exception. Now, this again is the administrative burden that patients and doctors have to go through to get these approvals. But this would really be, at least instead of having to wait a week or two, for a response, you're getting a quick response because in some cases, you could be in the middle of a flare up. You could be in the middle of a crisis that you need something like yesterday and not, 3-4 days down the road when your condition gets worse.
Yeah. And to your point, we all have experienced that some medication or some treatment for one person doesn't work the same for somebody else, so it's always kind of scary when when something happens, you're like, hey, what should I take for this? And like, ah, no, 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 no. Like it might be completely different for somebody else. So you want to make sure that you get that care. So, and I appreciate, the perspective to lupus. Our grandmother had, on my mom's side, had lupus. I have an aunt who's a carrier, doesn't have the symptoms as strong as my grandmother did, but my cousin does. So it just, you just never really know.
Yeah,
And
it's
she's had
very
to go
common.
through a lot of different treatments as well. Um, so thank you, Jeanette. I know we'll come back with another question later. So moving on to Joel, tell us a little bit about the telehealth utilization and expanding the access in particular, as we mentioned in the introduction, and has already been expressed about underserved communities. What's that access doing here and helping the underserved communities and also the rural communities, Joel?
Yeah, thank you, Marianne. So I want to go back just a little bit in time. So 23 years ago, I started this company and I saw such a huge need in pathology where pathologists were doing studies traveling across country with the glass that they
Oh,
would take specimens with to share with other colleagues to decide how to handle certain patients' disease. Imagine that a Harvard doctor flying to Stanford and another one from Columbia flying together just to see and go through slides together to collaborate on patients' care. And so we thought we could change that. I came out of semiconductors and we did machine screening with cameras. So we took that same technology and moved it into healthcare for pathology. And a number of years with pathology, trying to help them. We made some progress, but where healthcare really started to take the need in the late 2004, 5, and 6 was in primary care. And so
mm,
for the need for a patient that has a traumatic experience in a rural area to go to the local FQHC or health center and then not really able to get the care that they needed, they would have to be more than likely transported to the urban center to get the care in a very life-threatening situation. And so very early on, we decided that we needed to change what we were doing and focus more on getting the CTs where they needed to be instantly, and then eventually into the primary care and all the other modalities to help rural healthcare. Myself, one of the big reasons that I'm in this industry was my dad served in World War II in Korea.
mm.
And we lived in a small town in Minnesota, but there was a VA there, beautiful VA. My dad lost most of his hearing because he worked with big guns. And at about 5:30 in the morning, he would get up the day of his visit for the VA, and he would drive the mile to the VA that he needed to get care from. However, the care wasn't there. He'd get on a bus for 2.5 hours to St. Paul, Minnesota, where he could actually see an audiologist for his hearing. He'd wait there all day, have a 15 to 30-minute appointment, and then he'd wait the rest of the day, get on a bus, and come back to his hometown, get in his car, and go home. So a 30-minute visit literally was 14 hours.
Whole day. Yeah.
A full day. And so I knew that we could make changes based on, we did pathology, we did dermatology, we brought audiology into the mix as well. So now in the US, a veteran, even
Mhm.
an active duty service member, can get care for audiology anywhere in the world. So if a service member's in Qatar and they need to have their hearing checked, they don't have to be airlifted to the US to have that done. And so we have just seen that disparity of care that takes place just even within our own populations is even greater when you go to the Navajo Nation. It's greater when you go to Africa. It's greater when you go to other parts of the world. And so we just have seen and experienced that when you get the proper evidence within a healthcare visit, whether it's remote or in person, when the proper evidence comes in, I think all of us would agree that better healthcare takes place. And when better healthcare, sooner healthcare takes place, obviously, you should have the benefit of lower costs.
Mhm.
So that's what we've been focusing on for 20 years, 20 years. And but early on, I spent most of my time explaining to extremely intelligent physicians what remote care or telemedicine really can be. And I don't do that as much anymore.
Yeah,
And
probably not.
yeah, but I think that that there's a real big difference from just saying, okay, great, I'm going to go on my phone and see my physician, my provider. That works really well in behavioral health. But for the providers to provide the right diagnoses, they have to have evidence. And so we really believe that when you bring the evidence in live or in a store and forward manner, that really makes a difference. But I'm really curious with this panel and honored to be on this panel and great hearing about what you're doing at MAP, Chris, and Mr. Martinez at Allian and Jeanette. I'm very encouraged by what you're doing on helping reduce those steps and accelerate those steps. So thank you.
Yeah. One of the things that, Joel, as you were talking, I kept thinking about the way that I grew up. So my parents, of Mexican heritage, mom born in Texas, dad in Mexico. And my siblings and I, five of us, were born and raised in a farm worker camp in Central California. And we would pray that there'd be no major emergency, because if we had a major medical emergency, in the very beginning, they didn't have any health insurance. Later on, they did. Um, but you have a tractor that something happens, something happened, somebody fell into a ditch, and it would take 45 minutes just to get from what growing up as a kid, right? I said that
Yeah.
we 45 minutes from civilization. It felt like a lifetime.
Oh, yeah.
But it was also very real in that we also didn't have, like, we didn't know that we could pick the pharmacy we wanted to go to. We didn't know we could kind of pick doctors. Everybody in the same farm worker camp went to two doctors. Like,
Yes.
everybody went to the same two doctors. We went to the same pharmacy. And then the only time we got dental care, well, or quote, preventative dental care, was when my mother qualified for unemployment services because she was a seasonal worker. And the preventative dental care then was, we're never going to see these kids again, so just pull the teeth, you know? So we all have really bad dental issues, which is Jonathan's and my stories have go way back on that. But there's also been a lot of care, and I think people sometimes in some cities forget, just like even here in the United States, the lion's share of our land is rural. The
Yeah.
majority of our land and our, brothers and sisters don't live in big cities. We're in smaller rural communities. And so I'm curious, Joel, from your work, you know, being global in mindset and service, how much of the service really is US versus global right now that you're seeing or you're working in?
Well, so for Global Med, we're in 60 countries, but truly the need often is easier to focus locally. And so
Okay.
the US, we do a ton of video conferencing that has all the evidence built into it from all the devices. So it's the majority is here in the US, but we have projects throughout Romania and throughout Europe, and then especially in Africa. I always like the story where we brought in one country within Africa, we put in 16 different sites of technology in a backpack, basically, but with communications. And in those villages, you would normally see a nurse once a month would come to the village, and the story goes that if you got sick any other time or you had a situation any other time, the if they didn't have vehicles, they would literally carry you to the next
Wow.
village where they knew there would be a nurse. And so with the technology that we've deployed there, that changes it. And
Mhm.
think, one of the things that we need to, as we talk today is just hopefully we can talk about the policy of broadband is healthcare. It enables healthcare, where without broadband, right now in the US, back to what you mentioned earlier, 22% of Americans 22% live further than 30 minutes from any healthcare. And I thought it would be greater than that, but it's actually still 30 minutes. And 30 minutes in an episodic situation, it can mean a very terrible outcome.
Right. Yeah. Yeah. And even in some communities, as I forget what was mentioned in terms of like the health deserts, it's just scary. It's just scary when it takes you a while. And in some communities, you can only get around by public transportation, and that is not even always that reliable, right? So you kind of have to work your health access based on the bus schedule. And that can be a little even crazier. So, Dr. Kamal, I'm interested and we're all interested here to find out about what everybody's working on. And in particular, I understand that the Cancer Society and Pfizer have launched a new initiative, again, focusing on, we were just talking about, patient support, comprehensive support, and looking at the under-resourced by increasing awareness and just cancer screenings, a lot of different things. So if you can share a little bit more about, what is this initiative and maybe something else that you're also working on at the Cancer Society.
Yeah, well, very clearly, our mission is to end cancer as we know it for everyone. And the for everyone might be the most important parts of that phrase, because what we recognize is while everyone is at risk for cancer, the experience and the pull through of that is different based on populations, where we live, who we are, and various things that we're starting to better understand now. In the Change the Odds initiative, this is a very unique collaboration between Pfizer and the American Cancer Society to address what we've known for a while, but to bring solutions to this idea that rural cancer communities are oftentimes disproportionately impacted for various reasons, as was mentioned earlier, transportation, proximity to expertise, access to clinical trials. These are all very salient issues that come up, particularly because cancer care is not what it was 20 years ago. The need for speed and precision and focus on the experience is much different because we are, frankly, in a brand new era. There was a time where we didn't have treatments, and so solely our focus was on less on who can get access and more on do we have adequacy in the pipeline for interventions and drugs. And fortunately for us, because of the advancements of science, now we absolutely have to simultaneously worry about who are we serving, how are we serving them, and how effective is that service. Because fundamentally, to end cancer as we know it for everyone, we have to address everyone and their specific needs. And so I point to this idea that 1 in 2 men, so 50% of men, and about 33% of women, 1 in 3 women, will hear the words themselves, "You have cancer," at some point in their lifetime. And so that makes cancer an every person's worry, but it also means that solutions can also dig deeper into the particular needs of a community. If we look at the cancer continuum, we used to think of cancer as sort of being a monolith. It is a thing, it's big, it's scary, and it's still those things. But cancer care is also really well defined as particular stops along a particular continuum. So in that continuum are things like prevention, and prevention has everything to do with risk assessed behavior management and screening. And so if we look at particular populations in the United States, risk is not the same across everybody. That can both be because of dietary and lifestyle factors, but also baseline genetic factors. So we know, for example, that in certain communities in the United States that we need to be talking a little bit better about risk factors. One that continues to evolve are issues like unhealthy weight and obesity. There are 13 different cancers associated with not being at an unhealthy at a healthy weight. And yet, as a physician, I will tell you that being in an unhealthy weight is not a simple issue, nor are the solutions to that simple as well. But recognizing that that is tied to cancer risk may give a different sense of urgency or a different appreciation of the complexity of the issue, so that we can address that. Because ultimately, to bend that cancer curve, particularly the mortality curve over time, will be because we're leaning into communities and thinking about what each person's individual risk factors are. If you think about the rest of the continuum too, though, as we go through sort of prevention and early detection, we also recognize things like HPV. I appreciate, Chris's conversation about the global aspect of things, and a lot of what he mentioned in terms of the likely likeness with like Sierra Leone. We find in the United States alone, if you're in Rhode Island, the chance that your children got an HPV vaccine at a population level is probably in the 90%. If you're in Mississippi, it's going to be close to 25%. So those disparities are pretty stark, even with our own country, and even when access from a insurance perspective may be very similar. So while we have in some ways solved for that issue in this country, and even that may be sort of changing of late, there are many things beyond that. If you look at the rest of the cancer continuum, access to clinical trials is not equitable. If you are a person of color in this country, the chance that you are asked about a clinical trial is going to be probably in the single digit percentages. The chance that you actually enroll in a clinical trial, if you are a black man, for example, in this country, is going to be probably 2 to 3%. And that's all while knowing that some of the newest, best, and potentially most innovative treatments are actually found in clinical trials. When we look at concordance to guideline care, we also find that that is disproportionate both across geographies and demographics, and as equally access to survivorship and palliative care resources are also very different across this country. So while we like to think about cancer as a monolithic experience, the reality it is not. And to end cancer as we know it for everyone, we have to address the needs of everyone in the tailored ways and to meet them where they are.
So in terms of meeting people where they are, because it is so very different, what is this initiative doing to get to people where they are? Are you going to clinics, or how can people in the audience here, can they sign up, or how do we connect the two here?
Yeah, so we're doubling down on our efforts in the rural cancer space. So
Okay.
particularly, we are focused in 5 states, and we're looking at everything from community-based activations to large-scale sort of statewide initiatives to pay attention to a couple key areas. One is cancer screening, as I mentioned, and so that's thinking about events where we go to where people are. This idea that healthcare is patient-centered in theory, it's actually health system centered in practice, right? And so bridging that gap is actually the point of working together in this type of way. Also focus on clinical trials, and again, survivorship is the 3 areas of focus within the initiative. In terms of how people can access it, I mean, it's really given us the platform and resources to be able to do what we do as an organization in an excellent way and even a bigger way. So I hope people across the country are sort of seeing ACS show up in their communities, maybe in a different and more robust way. And that's because of this collaboration.
Okay, good. Yeah, because I know that obviously in different communities, there's different programs going on that are usually kind of tailored to the needs of that community, to your point.
Sure.
Every community is a little different, so definitely want to hear a little bit more about that. And you're right. I think part of it too is that at least in a lot of our communities, rural communities or just uninformed, um, we don't really focus a lot on prevention. I mean, sharing even like with the way I grew up, we didn't really focus on prevention. We didn't think about it, right? You just kind of go along, and then when you're sick, then
Yeah,
like the world is ending, then it's like, oh my gosh, can I get this, or where do I get that, or how much does it cost? So I think a lot of I think in a lot of times when you're poor, um, and you're just kind of in a survival mode of just
sure.
overall living, that prevention doesn't usually make it. Your prevention is eating like as healthy as you can, moving around. And so I think that's part of the other challenge, especially in certain communities where we don't really, we know the doctors are there, we know the clinic is there, but we don't go.
Yeah. Well, as the son of immigrants too, I think oftentimes when we think about disenfranchised populations or under-resourced populations, one of the things we commonly think about is a sense of control and agency, right? And oftentimes that's actually the challenge. To your point, you may feel like you only have access to 2 different doctors, right? And so that in and of itself is a built-in inequity that is sort of rooted in this idea that you don't have choice. But what's really interesting is in the cancer context, that about half of cancers have a modifiable risk factor. What that means is that you do have choice, in fact, because if you think of cancer as being, bad luck, bad genetics, which has historically been the way we've sort of thought about it, right? When you don't have agency, it's really easy to ignore something. There's a lot of things I don't have agency about related to any number of things. And so I don't give a lot of attention to those things that I don't have control over. That's sort of the human condition.
Right.
But if we reframe this to say that your risk of cancer is something that you have control over in any number of ways, then what more empowering message is
Mm.
there for all the
Mhm.
communities who are worried about this risk?
Yeah. Yeah. No, it's interesting. It's a whole fascinating how I think some of that thinking is also beyond just cancer.
Of
It
course.
applies to a lot of things that happen, not here in the US, but just around the world. I'm going to come back to Jonathan. So, we've talked a little bit, Joel is definitely in the innovation space here. But Jonathan, share with us a little bit about from an innovation perspective, um, how has that changed over, let's say, just the last 10 years? And what you're seeing from not just Haleon's perspective, but from that industry perspective.
So two things there. I think the first is if we think about how many RX products are brought to market every year, usually that's somewhere around 50 products a year, right? And that includes the biosimilars and all that other good stuff. When you look at innovation from, getting those RX products that have been found to be safe and effective and moving them to an over-the-counter setting, you're probably looking at innovation to occur once every 7 years, right? The majority of products within the last 20 years, about 84%, 82% of those are what are known as follow-on. So in other words, they usually are based on the monograph, which is what, determines which ingredients are, you can put in over-the-counter settings. And so that has led to a gap. You think about perhaps the last biggest innovations in the OTC space. You'll
Mm-hmm.
probably think right off the hand Narcan, right? If you're thinking about pain management, you're probably thinking Voltaren. If you think about allergies, you're probably thinking Flonase, right? So I'm sharing a couple of name brands that, we've probably seen, when we go to the store. And then from there, it's kind of limited, right? And so when you look at even how Voltaren is treated in, say, for example, the UK. The concentration of diclofenac is higher versus the US, right? And so that means that you
Ah,
can, provide it for more indications to address more conditions, right? In the US, we're limited to arthritis care versus other markets where a product with a slightly higher percentage of diclofenac can be used to address other conditions. And so it's thinking a little bit about and I nerd out, right? I'm the kind of guy who on Saturday morning goes to the pharmacy just to check it out. You think about all the
yeah,
products
people
that,
don't just get up and go to a pharmacy,
yeah,
Jonathan. That's
no,
not the
just
thing to
just
do on
little
Saturdays.
old me here. But you take a look at what's on your shelves, and there's a lot of choice, right? There's a lot of options, but you look and compare that to some of the other markets we've talked about, right? You go to the UK, which has a very different approach when it comes to addressing pain. You look at even items like smoking cessation, right? Smoking cessation has been stuck in innovation world since the 70s, right? And
Yeah,
so for
yeah,
context, Zyn is a very popular product, right? It's not in the smoking cessation world, but there are more Zyn flavors than there are, say, for example, smoking cessation flavors. And so even that, so thinking about when we think about how we can better improve the patient experience, I think we've got to think about where we have those gaps, right? Where can we better meet patients while keeping it affordable, right? Because again, there is research
yeah,
out there that shows that if you charge too much for an over-the-counter product, people just won't do it, right? They just won't buy it.
yeah,
And you've got formularies in states that no longer cover these over-the-counter options. So it's fascinating because unlike our RX friends, as the OTC people, we got to think about two things. One, how do we keep you healthy? But two, how do we keep it affordable that you actually buy it, right?
right.
Because and that's something the RX, traditional legacy pharma companies don't have to worry about. They'll negotiate that with the formulary. They'll negotiate that with their providers. Um, we don't have that. We don't have that. Some people would say limitation. Others would say opportunity. I think it depends on how you see it, right? But definitely an opportunity because it allows us to meet consumers and where they're at. And it's the reason why you've had so many companies spin off their consumer brands, right? So, we were the first, right? So originally we left GSK.
Right.
Johnson and Johnson followed shortly with Kenvue, and then most recently you look at um, you look at Opella, which is a spinoff from Sanofi, right? So there is a recognition, right, that you have these two distinct portfolios where you've got the RX world and non-RX, right? And how we show up for patients is different in these criteria, right? So you've had FDA recently put out final rulemaking for additional conditions for non-prescription use, right? So ACNU,
Right.
and the idea there is to use technology as a lever to try and get people to, select a product based on their needs and their pharmacist. It might be helpful in communities where you don't have as many pharmacists, right? The idea here is to help people find an alternative, to RX products that might already not be covered in their formularies. And so I think there's just a ton of opportunity. I just think we have to be creative. We have to be bold when it comes to how we address patient conditions that can be, addressed with ingredients that are safe and effective that FDA has vetted. And how do we bring those to market in a way that consumers can understand, right? Because when you've got an over-the-counter label, it's very different than the little piece of paper you get at the pharmacy, right? There's a
Right.
process for that.
Right.
So how do we think a little bit about how we change that, right? Because I do think, we've talked a little bit about weight issues, right? Obesity and stuff like that. Um, we don't think twice when it comes to buying perhaps the extra sugar or the added sugar products, right? So how do we think a little bit about, trying to use that experience and put it in as part of, an over-the-counter experience, right? To help people understand, right? Like, okay, if you're going to use this product, this is what the probable outcome will be. We work in tandem with our friends in the space, right? We work in tandem with FDA too, and we try to get to that happy space. I call it the sweet middle, right? Because again, it's not it's not easy, right? You try to take everyone's collected experiences, whether it's the person who has a PhD to the person with limited English proficiency. And the goal here is to try to get as many people in one tent so that they can understand what product they're using, its effect, and how it would address their conditions. The OTC space is a challenging space, but it's a fun one, I promise. Mostly because again, you try to make product accessible and available for people in a way that otherwise probably you wouldn't necessarily have to deal with in the RX space.
All right. Oh, no, thank you. I appreciate it. And I'm sure there's another question, but I want to make sure I'm catching all of everybody's input here. Jeanette, I'm going to come back to you. So, on the advocacy side, share with us a little bit of what's happening with, cuts in to Medicaid. And, anything in related that you're working on from an advocacy standpoint that we should all be aware of, in regards to Medicaid right now.
Great. Yeah. Well, first of all, to level set, we need to know that 20 million Latinos in the US rely on Medicaid for health coverage. And more than half of Medicaid beneficiaries in the US are children, people with disabilities, or older adults. So as a result of the new law, states will, what's most concerning is that states will implement work requirements for Medicaid enrollees. So it's particularly for those who gained coverage for Medicaid under the ACA expansion. So what the work requirements are going to require is that they document that the beneficiary, the enrollee, works or volunteers 80 hours a month. And the Congressional Budget Office predicted that this will lead to about 5 million people losing coverage by 2034. So not immediately, but it is significant. And what's interesting to me is that the work requirements combined with eligibility changes, like now they're requiring renewals every 6 months instead of every year. Those, just the fact of those changes are going to cause eligible people to fall off the rolls. So people are, life gets busy. We forget to re-enroll. We have to do all this paperwork, right? And as a result of that, eligible people will forget and will fall off, will lose coverage and not know it, and may go, oh, I didn't realize I didn't have coverage. Another thing that, as a public health advocate, what seems like a cost saving, right, to not cover this population. A lot of times, these are the healthiest people to insure. They're cheaper to insure because of that, and we want to make sure that they're continuing to get their preventive screenings, like cervical cancer screening. Things for you want to screen for all the cancers. You can screen for diabetes, cholesterol, HIV. These are just the things that are important to young adults, like the 25 to 39, year olds. But public health is all about disease prevention, and screening definitely helps to catch those problems early on while they're much cheaper to treat. So, ultimately it reduces the uncompensated care for hospitals. So, like, instead of ending up in the emergency room with a
Emergency,
late
yeah.
stage diagnosis. And the other big concern, as we were talking about rural health disparities earlier, is that rural hospital closings are still a concern, even though the bill included like a $50 billion for rural hospitals. It only offsets a third of those cuts. So, for example, in Texas, 69% of rural hospitals are projected to reduce or eliminate essential services. And so this is where they might, close down labor and delivery units. I always feel like that's the first thing to go. Hospitals decide to cut services. And as it is now, for immediate concerns, like 22 hospitals are now under imminent risk of closure in Texas alone.
Wow.
In Florida, like for example, Florida's Health Association published some comments, and they mentioned that already their program doesn't adequately cover children, older people, and people with disabilities because reimbursement rates are too low. So if we're cutting funding to states, that are already, I would say, trying to, bridge the gap, it's going to again lead to more, moms not being able to go to a nearby OBGYN, having to travel even further, right? These are just the rural hospitals. Children aren't going to have access to dentists, right? We're going to know that.
Yeah, yeah.
It's suboptimal care in, where we could be having, the state of the art care. So that's
So
one of the things that's concerning about the potential squeeze on the healthcare systems.
on your organization's website, do you have this information or information about the legislation where people can look up, for themselves what's going on and if they can, how to reach out to their legislator, whether it's at the state level or even at the federal level?
Yeah, unfortunately, not yet. We are so
Okay.
new. We just started, but that's definitely on our list. I will refer folks to Families USA. That's a
Okay.
wonderful place to go to for information.
All
And then
right.
they have also that the function where you can write a letter to your legislator.
Okay, perfect. Yeah.
Yeah, because though these will take a few years to implement, some of the immediate impacts are going to see those like squeezes to the healthcare systems, because then as the states start to implement their work requirements and start to implement the other cuts, I think that there's still an opportunity for consumers and
Yeah.
for patient advocates to make a difference and a change on a state level.
Yeah, I mean, it's always important to tell people, from the advocacy side and just, where do you get, like some of the legislators are also navigating the whole change too, right? So they're trying to get information, they're trying to figure out, so, we're all kind of in the game here together. So they listen to their constituents. And so we need to make sure that people make those phone calls, they send in those letters, and make sure that, as the legislators are doing their work and doing their homework, that you're part of that homework assignment, that, they're reading your information or they're hearing the message that you left in the office. So please, everybody, make sure that you do that.
Marianne,
Back,
can I just add, and Jeanette's absolutely on point. The other issue to consider, right, is that the work requirements do apply to caregivers of adults with serious illness, and I think that's a pretty big miss. Just from the cancer perspective, 2 million people annually, 18 million survivors, their caregiver, right? The health of that person's caregiver is critical to their ability to being a caregiver,
yeah,
right?
yeah,
And so we worry a ton. And for us, our ACS CAN, which is our advocacy arm at fightcancer.org, that's a lot of our worry is that work requirements are typically not as straightforward as one might think, particularly for cancer patients who, for many of them, are facing a long journey, but need a lot of caregiver help and time and attention of that caregiver and the health of that caregiver to be present for that to
yeah.
occur. That if you start adding work requirements to that caregiver, it creates sort of a false choice between do I care for my loved one or have to go do a work requirement to maintain my healthcare coverage.
Yeah, no, that's a really good point. And I think a lot of us are getting into that space where we're looking at if we're going to be a caregiver for our parents or, you know, literally just had that conversation with my siblings because our dad is, God bless, he just turned 92. But he has dementia, so we're navigating, here we think we're all educated college kids and we still don't understand all the medical terms, right? So there's a lot of that information. I'm going to come back to you, Dr. Kamal, but first I'm going to go to Joel. If you can please expand a little bit, Joel, on the telehealth and how you've seen improving patient outcomes, especially in the rural and underserved populations.
Yeah, excellent. Thank you. Amazing, Jeanette. Thank you for that too, and Dr. Kamal. When I look at each and every one of the points that you've all brought up and the issues and the problems, I get into this, I can fix that mode, right? My wife
Good.
my wife doesn't always appreciate that I jump to a conclusion, but you know, so my favorite story is a small town in very rural Arizona near the border. Now, they have a hospital there, but that hospital really only took care of a broken arm type of thing. You would get airlifted either to Phoenix or to Tucson. And so the town was somewhat dying. Yet there was a lot of building outside, but people were reticent to move because healthcare was 80 miles or 2.5 hours away. Right. So they years ago they got wise and they decided to put in some telemedicine. And so the very first thing they did was STEMI or heart attack. Well, the data came in very quickly within the first 6 months of that technology being in place, where if someone presented with a heart attack, they could go ahead and bring in a cardiologist and decide not to spend, if not necessary, $12,000 to airlift the individual because they didn't know to Phoenix or Tucson. And what was the side effect on that? What happens when your family member, your loved one, ends up going into an emergency room via helicopter or transport? The whole family gets in their automobiles and rushes to that city to be there for their loved one, right? So within the first 6 months of them having that technology, with 36 patients that presented with a potential heart attack, 29 of them stayed in that rural town at rural hospital overnight. And to your point, Jeanette, of the closures of hospitals in rural America, that hospital went from operating in the red to operating in the black because they had the overnight stays. And then the next thing you know, they added stroke, and then they added dermatology, and then they added pediatrics, all virtually, right? And so on. So some of the biggest proponents of that technology and of what's taken place in that small town was the mayor, not just the CEO of the hospital that now is operating in the black and gets to keep his hospital, but the mayor, because little shops opened up. People would move there because they could get pediatrics, so they'd bring their young family there, right? And so when I look at Dr. Kamal, you know, talking about cancer and trials, and Jonathan on trials for medicines, the cool thing about telehealth is that those clinical trials can happen just about anywhere, and the color of one's skin does not matter, right? Unless you're trying to go after a certain population that maybe is high in circle cell anemia, right? Then you're going to obviously want to do that with a tight group. But telemedicine is the great equalizer, and I don't care if it's in the rural area or the urban area. Sometimes to get to the hospital in the urban area is near impossible, to your point about the transportation, Marianne. So I have some strong thoughts on this, but I think I can fix some of these situations.
All right. I love this. I love that we're going to have a solution here after this. So, and obviously a lot of people, because of the global, the shutdown with COVID, there's a lot of people that are looking at telehealth, telemed, whatever you want to call it now, in a completely different way, you know, from a provider, an insurance, a patient, you know, all of that. So with that, I want to track,
Marianne, AI triage. Okay,
wow.
so AI triage, amazing. So the workers out on that farm or where you lived growing up, most people have smartphones. And so literally with AI triage built into a telemedicine or telehealth app, that all changes because you can get a fairly good diagnosis that then is backed up by Dr. Kamal and others, this seems like where you are at, and then give you some guidance of how you need to take care of your care. So
Yeah.
that, I think there's a lot of change coming.
Yeah, it is an interesting time with innovation in terms of everything that you've all, mentioned. And to your point, Joel, people in any situation, almost everybody has some kind of a smartphone.
Yes.
And how do we use that, for more good, instead of downloading more social media memes? So,
Yes.
um, Dr. Kamal, coming back to you, dear, what else is the American Cancer Society working on in terms of the health equity space? And again, as we're getting closer here to wrapping up, any particular websites or initiatives, along the one that you mentioned earlier that people need to go to get more information?
Yeah, well, I think there's a lot of things we're doing. I'm particularly proud of our Cancer Risk 360 platform we just launched, and the
Okay.
idea there is people can take a 8-minute online free quiz to understand specifically what practical behavior changes can they start doing today to measurably reduce their risk of cancer. That is things that I, even as a well-trained doctor, didn't know, right? So for example, the difference between instant oatmeal versus whole grain oatmeal, overnight oats, or steel cut oats. One will reduce your risk of cancer, the other will not. And so that's the kind of thing, right? Where it is truly, a simple change that you might make the moment you walk into a grocery store or taking a walk and a walking meeting versus sitting in your office. So all things that can measurably do that. I think the other thing is that, while people fuss with language, I'm not fussed about language. The American Cancer Study exists to end cancer as we know it for everyone, and that's because there are differing outcomes happening throughout the country. And fundamentally, I don't believe that's okay. And I fundamentally believe that those are solvable problems. And so, if they're solvable problems, that means with conviction, we have to go in and find the drivers of that, be it demographic, geographic, socioeconomic, et cetera. And I think what you're going to see now in cancer care, including the American Cancer Study, is a real deep appreciation for the non-biological drivers of those outcomes. And so
Mm,
that means we're investing in things like addressing food insecurity and obviously
yeah,
transportation and lodging and social isolation. Because while we have solved for the availability of treatment in many different ways because of R&D over the last 20 years, we have not yet solved for the accessibility, the equitable accessibility of those treatments. And an innovation that is only accessible by some but not all is in itself a form of injustice, right? We cannot be creating things that not everyone can benefit from because there is so much excitement and
that's
innovation
true.
in cancer. But that's only exciting when realized by anyone and everyone who needs access to that thing. And that's why we exist as an organization. That's why we do the work we do by being the largest non-governmental funder of research, the largest advocacy organization in the cancer space, and certainly in the patient support services we provide, touching nearly 111 million people per year. But that also means that in our programs and services, we do not restrict for any particular background or not. So people oftentimes hear, we serve 550,000 people in our Hope Pledge program. As a rule, I don't care what your payer is or if you're self-pay or you have wonderful insurance. It doesn't matter to me. If you have a need, then you get to stay with us. Same thing
Yeah,
with demographic and every other background. And so I think that making commitments like that are really important for organizations like ourselves. And we will continue to do that in all the different ways.
I appreciate that. So it's called what? Cancer 360? Is
Cancer
that
is 360. I see the link is here in the chat.
okay?
I
Good.
encourage everyone to take it, and I challenge you to learn something new today that you didn't know. Again, 7, 8 minutes. You can do it in the
Yeah.
background of other things
And
that you do.
whatever the majority is that we need, we're gonna send it to Joel so he can fix
Perfect.
it.
Perfect.
Right. Okay.
Thank
Well, we've had such really good information, so I'm gonna kind of fast track us a little bit here. I'm gonna go back first here to Chris, and then I think I'm gonna do just a couple of broad questions to everybody else. So, Chris, if you can share with us a little bit of how does MAP International, how do you access um, the medications, and then also just kind of a combo question, how does that medicine impact health outcomes? for those that you serve.
Yeah, thank you. And I'm learning so much. I'll be lean with my expression so we can be good on time, but I'll just give a quick mental picture for those who are on the call, who are listening. And I traveled recently to Sierra Leone, Freetown to Bow, which is like east to west or west to east across the entire country. Saw the whole country, and it was about an 8-hour drive. You can imagine, nice highway. Most of what you'd see on left and right would have looked like Nebraska. It was either agricultural with just crops that just went and went and went, or it was Sierra, not rainforest, but Sierra, broad Sierra, right? So in that trip, in that 8-hour, 9-hour trip, I didn't see one oxen, didn't see one horse, very few cows, not one tractor, and yet you had all these fields. And what that means is every bit of movement, every bit of labor comes from a human body. That means mom and dad are working with their physical bodies, and if one breaks a leg or one gets sick, that also means every bit plant gets moved or planted by a human body. That's the world that exists there. And then in places like Guatemala, Dominican Republic, you might see more tractors and fruit and vegetables and just so much more abundance. So for MAP International, we get product in that environment. That's who we serve. We get product from the world's most generous generic and branded pharmaceutical companies. We also get a lot of over-the-counter medicine that is so, OTC is so critically important in the United States and then internationally. Distributors are very generous. And then clinical and surgical supplies, med tech supplies, just so much. And if I were to walk in the back warehouse today where I'm at, we've got just 82,000 square foot of pharmaceuticals. And, one exciting thing I could go see, for instance, is donated pediatric heart valves. Every box is worth $8,000. Every one of them has a GPS tracker. We've got a whole wall of them. And if we get a call that there's a missions trip going to Ethiopia, we would send, 20 of those, all of different sizes. So that's who donates. Then we're sending out to about 300 very large, very carefully chosen NGOs, government organizations, charitable organizations, and then a lot of other things, individual, oncology hospitals, peds hospitals, clinics, MASH units, outreach things. We then have a smaller bit, which is targeted pallets that might go to facilities. We have another piece, which is emergency response pack, where we have 4 pallets ready to go that we can drop 4 of them, and it will serve in an emergency response situation, 10,000 people for 2 weeks. And then we've got small like mission sending. I'm sure a lot of the folks on your call have called MAP because they're going to do a primary care visit in some location and Bolivia, and they would call us and we'd send. So that's kind of the relationship to and from. And then in between, of course, there's a warehouse sitting in Brunswick, Georgia.
Great. So I'm going to ask all of you one last question. I think we have maybe 1 or 2 questions here from the audience, but I'm going to change up the question a little bit here. So let's pretend that we are all going to be talking to members of Congress. We've all been called to talk to them and to share with them what do we think, based on our expertise and our industry and what we do, are the top 2 priorities in terms of health that they need to focus on. So Jonathan, I'll start with you.
I would keep it simple. Innovation is good, right? So bringing more of those products if we can, trusted ingredients that have been proven with other clinical studies, bringing them over the counter. And 2, affordability, right? We know that the over the counter is affordable for working class families. We got to keep it that way. You think about the conversation about tariffs and pharma. I think a lot of folks forget that the term pharma also dovetails to over-the-counter products, right? So just making sure that when we, look at policy, that we make sure that we do things in a way that keeps products affordable.
Okay. All right, Jeanette, what are your 2 top? We're all members of Congress here. What are your requests?
My top request is to increase diversity of the healthcare industry, particularly for Latino communities. We are the growing demographic in this country, and we need to increase recruitment, retention, all of those things, so that we have the healthcare workforce to treat our communities. And I have to mention, the community engagement is so important. We should really foster partnerships with our community-based organizations to create scholarships, fellowship opportunities. And one thing that legislators or states can do is provide student loan repayment programs for students that go into service in underserved communities. That's one way. We've seen rural health fellowships work really well to get those, get that talent to go in 2-3 years in an underserved community. And it serves as a wonderful training ground for those young professionals. And then if we see, we're engaging with Hispanic serving institutions and community-based organizations, we also should include mentoring within the healthcare industry executives. We don't see a lot of Latino healthcare professionals, leading hospitals, right? We also need to see that as well.
Okay, great. Dr. Kamal, how about you, dear? What would be your top two in a room of Congress members?
Research. We did
Okay.
not get to where we are without investments in research. Cancer mortality is down 34% in the last 40 years. That was not an accident. That is because of real intentional investments in research. And there are significant cuts proposed to the NCI and the NIH. And fundamentally, I don't think cancer is a partisan issue. Because it affects everybody. And so, I would kindly ask that we, continue to invest in that research, because if we do not, that mortality rate is at risk of rebounding in the wrong direction. The second is, I'll say, caregivers. I think, many of my panelists have talked about this too. We cannot underappreciate the value of caregivers, and whatever appreciation looks like, we should think about whether that's payment through payers, whether that's, making programs that really support caregivers. Caregivers are the backbone of the U.S. healthcare industry. And I don't mean paid caregivers, I mean family caregivers. They're the
Yeah.
ones who are taking care of the people I care for the 99% of the time they're not in my office. And they go under-recognized, underappreciated, and under-supported. And that is playing a little bit with fire, because we have more serious illness than ever before, more reliance on caregivers than ever before. And we need to intentionally invest in programs that support those folks.
Good ones. Chris?
Yeah, thank you. I'll give you two domestic and one international, and a little wonkish, but domestically, we need to keep strong reimbursement for federally qualified health centers and rural hospitals. That's absolutely critical. They produce great outcomes. The FQHC system produces great outcomes and is needed. But at the same time, we need some transparency with the 340B program to keep it sustainable. So that's two there domestically. And then internationally, the USA to return as a driver in global health through programs that we'd see, such as through USAID, such as PEPFAR. PEPFAR has saved an awful lot of lives. It is a powerful program. The cost is low, the return is high. There are just such shining examples similar to PEPFAR, and the US needs to be active there.
Well, I know that, Chris, that President Bush, that was, PEDFAR, that was one of his big initiatives. So I'm sure he's really happy of the two of us here for mentioning that.
Yeah.
Joel, how about you, dear?
Oh, thank you. I'd just like to say that I would tell them that telehealth is not a type of healthcare. It's not a modality of care. It's more like, and it's not like, well, I guess it's not like, it's more like gasoline in as to transportation. It's the fuel that powers every delivery model, whether that's a community clinic, a major hospital system, or a specialty provider hundreds of miles away. So for rural communities, that fuel is transformative. It removes geography as a barrier. It ensures timely access to specialists and makes preventative care like screenings, as we've talked about, in early interventions, more accessible than ever before. This is critical when a delay can mean the difference between a manageable condition and a life-threatening emergency. And to truly unlock telehealth's potential, bipartisan and cross-sector collaboration is essential. Policymakers can strengthen broadband access and reimbursement parity. Healthcare organizations can integrate telehealth seamlessly into their workflows, and technology partners can keep innovating for better security, interoperability, and user experience. So progress shouldn't just be measured by adoption rates, because that's what they've done through COVID, is adoption rates of telemedicine. We should track measurable improvements in health outcomes, earlier diagnoses, reduced travel burdens, lower costs, and higher patient satisfaction. And I think that's how we'll know that telehealth is delivering not just access, but excellence, especially in the communities that need it most. So I'm encouraged by all of you. And when I grow up, I want to be like Chris and do what he's doing.
Well, no, thank you all. I think we have like a question here I wanted to share too. It may not apply to everybody, but the question is with all these major cuts and different changes, how do we navigate that? How do we navigate this? Or maybe where do we go get information? So who can help kind of kick that off? Anybody?
Technology.
Technology. Jeanette, I'm thinking from an advocacy standpoint, is there anything that you would recommend for everyone who's concerned about these changes or cuts?
Yeah, so these cuts are going to be implemented at the states. And so I think that advocates now and consumers, we all need to start looking to our local leaders and then relying on our local community-based organizations that already provide services, your FQHCs, Las Clínicas, and support them, because they're going to be hitting the squeeze as well. And I think that if we do any sort of community event, always think, how can we help, raise money for our FQHC, or how can we help, La Clinica, because that's, I think, sometimes those and the community health workers are the ones that keep the communities going.
Yeah, yeah. So, well, thank you, everyone. Very much appreciated. I love all the connecting as well and learning from new perspectives, different perspectives, both here in the US and abroad. So thank you very much. Thank you for your support. Thank you for your participation and what you're doing. And for the audience, I hope you have an opportunity to go back and look at those links and see, where you can contribute. You've got information as well. You can reach out. I suspect most of our speakers here are on LinkedIn. You can check in with their offices, with their colleagues for different engagement opportunities at the community level. If you're also someone who's interested in the health field, we definitely need you. We need more people interested in these arenas, whether it's caregiver interest, whether it's a technology interest, advocacy, understanding, issues that we face with neighboring countries and those a little further away from us. So we definitely need some more people in this arena. And with that, thank you. And I'm going to pass it back to Nicole.
Thank you, Marianne, and thank you to this wonderful panel for joining us here today to share their insights. I'm going to one last time encourage you to please share what you learned today using Catch Skills. Again, a member of our team is going to share a suggested prompt that you can use to submit your very first log if you're unsure what to submit. The recording of this webinar will be uploaded to the CHLI YouTube page, so you may go back and review it later on. Thank you so much again to our moderator and our panelists. It's so important to share the good work that these organizations and companies are doing for our community. Now, before I let you all go, I want to remind you all that on September 30th, the Congressional Hispanic Leadership Institute will be hosting its 14th annual Global Trade Symposium. So you can also look for the sign up link in the chat, and we hope to see you there. This now concludes our program. Thank you for joining us and have a great afternoon.
Thank you.
Thank you, everyone. Have a blessed day.